Okay, dear friends, thank you very much for the invitation, and I apologize if I should proceed with some pictures which you would recognize again. It just speaks for the problem. We do not have enough information, despite, as we thought, 400 years are passed since William Harvey described this normal circuit, and my topic is back to the roots, the Valved Fontan conduit. And I would try to share with you my ideas, if it makes sense or not. And I am back to this picture, but I would go a little bit deeper in this problem. And as I said already, William Harvey described the normal circulation. He did not describe the Fontan circulation. He would say it is terrible to think that the circulation can deal in this way. And what he described in this well-known publication, which was published in Frankfurt, 1628, he demonstrated that if you press on the vein, and these points are the valves, what he emphasized in his drawing, if you press on the vein, then it's no flow more, no backwards flow through this valve, backwards to the other. This was originally what he emphasized, and this that he believed that the veins allowed blood to flow to the heart and maintained one-way flow. And this picture is that shown us that William Harvey described this normal principle of circulation to the King Charles I. And this is the next king, Charles II. And therefore, the story of the normal circulation is the story between Charles I and Charles III, up to nowadays. So is it. The life of Charles I was interrupted by a mysterious way, but we do not talk about this now. And then William Harvey explain also to Charles I what is the principle of the normal circulation. This is a drawing from this publication. And he said that kidney and liver are connected after each other to the heart. Therefore, it is not difficult to understand why we would have problems if this way have any other flow problems. And if we would say to William Harvey that this should be the normal circulation, he would laugh about it, because also 400 years ago, he understood that it should be in some other way, not in this funny way. And what we know, the free flow in the superior and inferior caval vein is not really possible, just because this is Niagara Fall, and Niagara Fall running in this way, not in this. And also, if we hope that will bring to the normal Fontan circulation, then this circuit is limited, what we all understand. And I don't know some mechanical solutions can help the Niagara Fall to running against the gravity, but I don't know any one of this. And this is a problem eventually why one of our patients have a normal Fontan circulation with good ventricular function and antegrade flow, and the other one, for example, some part of backwards flow, and this is the right ventricle, and we have 1 liter of cardiac index lower in his circuit measured by MRI. Why is it so? Different points were emphasized over the story of Fontan circulation. First of all, cyanosis, volume and pressure overload of the single ventricle, and also 20 years ago in this excellent publication of the group of Professor Horn, Professor Anderson, it was demonstrated that also the normal tricuspid atresia, where we would expect the so-called left ventricle, do not have normal myocardium. It is hypertrophied. The middle layer is significantly thicker compared to the normal left ventricle. We have interstitial fibrosis in the patients who were 2 months or 4 months old and 2 years old. Therefore, this is not sometimes a problem that we summarized over 20 years. It is from the origin, the problem in this myocardium, and we do not really can do something against it. The next point, of course, is the kidney function, And we know that we need about 5 liters of the flow, and a quarter of this is running through the kidney, and then we have the normal function of the kidney, the normal efferent and efferents, and what we have in our circulation: reduced preload, as we know, reduced circulation, elevated venous pressure, chronic cyanosis. Therefore, what we have at the end, we have this problem. We have enlarged glomerulus, we have dilated vascular bed, we have shunting, and we have glomerulosclerosis with not a normal function. Year longer we stay with Fontan circulation. And it was already summarized in some publication. One of these is from Australian and New Zealand registry. 300 of 1,600 patients were analyzed, and they said that the freedom from Fontan death and transplantation was clearly correlated with the kidney function. Glomerular GFR under 90 was better as more than 90. And then in this publication, it was demonstrated this is related to elevated central venous pressure. But we have elevated central venous pressure from the beginning of the Fontan circulation, cannot be other. And in adult congenital heart disease and acquired congenital heart disease, the numbers are a little bit higher as in our population. They demonstrated that according to the elevated central venous pressure, the glomerular filtration rate decreased in all patients, and it decreased more if the cardiac index is diminished. Therefore, this cardiac index of 2.5 had worse prognosis as the patients with the better cardiac index, but in relation to central venous pressure, the future is similar for them all. And we start with this pressure. What should we expect? Over the time, they demonstrated also that central venous pressure more than 6 millimeter mercury, and it would be excellent for Fontan patient, lead to this problem over the time. And it predicted mortality in association with reduced glomerular filtration rate. With the liver problems, it was said enough of this. We have this congestive hepatopathy because of decreased flow, decreased saturation, and decreased hepatic venous pressure. And why I emphasized it? Because it is also from the acquired cardiac disease, and they say a lot about tricuspid regurgitation, as yesterday was already discussed. We have the combination with severe cyanosis, and we have this so-called specific hepatic illness with elevated reduced cardiac index and atrophy of the hepatocytes and elevated central venous pressure and liver fibrosis. It was demonstrated in different publications. It is always in blue, this portal and sinusoidal liver fibrosis, and it can be shown also macroscopically. And this publication was demonstrated this fault is a prediction for Fontan failure with accuracy in sensitivity and specificity, and association with fault. The Fontan failure is not more far away from this problem. And not only in this macroscopic and microscopic changes in the tissue of the liver, but also in the functionality of the liver. It was measured with this methylcetin metabolismus, and it was demonstrated with Limax that over the time, the function of liver reduced, and somewhere it is under the line, under the borderline, and it is also associated with elevated central venous pressure, pulmonary arterial pressure, and it associated with Fontan failure. And now I come to the part of my lecture, such a kind of phlebological part, what was already discussed. And the question is, it is a small quiz show. What would you say, what is the pressure which is necessary to open this valve? Who would say it is about 10 kilopascal? Who would say it is about 1 kilopascal? No one. And who would say it is about 5 to 7 millimeter mercury? The majority. The correct answer is 10 kilopascal. Do you understand what does it mean, 10 kilopascal, if we try to output it in millimeter mercury? It is about 100 millimeter mercury. what is necessary to open this venous valve. I was really surprised also as understood it. And in this publication it was demonstrated. It is computational phlebological model of the venous valve, and they use this pressure to open this valve, which is demonstrated in this picture, and to move the blood from peripheral to central heartward. They wanted the blood moves heartward. And why is it so? It is really the venous pressure here is about 100, and it decreases heartward, and as we know, it is about 5 millimeters mercury in the knee of the tricuspid valve, if we hope that it is so. But our circulation stops in the best solution about 10 millimeter mercury, and in the worst solution about 20 millimeter mercury as a failing Fontan circulation. And in real life, it looks so that this is, for example, our surgeon after 8 hours operation with 100 millimeter mercury in the foot. And if we have muscular contraction, then we reduce this pressure from arterioles to venulus about 20 millimeter mercury. And this is the way if we run enough. Therefore, move ahead, it is a very good solution, or remain in the horizontal position for the whole time. If that, then we will have about 20 millimeter mercury also here. That it cannot be recommended, and this problem we saw already. This is the vein where the valve has no normal function. It is antegrade and retrograde flow in the same valve, and why it should be other in our circulation, as is demonstrated here for these varicosis. Of course, we will have the same over the time, and we have it as we know. Therefore, the venous valve can be found everywhere except vena cava. But the pressure conditions from 100 to 5 lead the blood flow in the heart direction. Therefore, from peripheral to central, as in this excellent Fontan sample, or from central to peripheral, as in this sample. But it's still the same Fontan circulation. Eventually, we can improve this flow if we put some valve in between to reduce this backwards flow. And it was already done 40 years ago. For example, it was a suggestion for early postoperative care with so-called anti-shock air pens. The pressure from external over all veins, lower extremities, and if you want, you can find it also nowadays in modern, but for massage, not for Fontan circulation. They cost about 1,000 euro. Eventually, it should be prescribed for every Fontan patient on discharge, and they can use it in the horizontal position, and then we will have still excellent Fontan circulation. Why I talk about tricuspid regurgitation before? Because the tricuspid valve is designed to be incompetent, and it was said already 1837. Because of this continuous dilation of the ring of the tricuspid valve, and also in acquired cardiology, we have such a kind of graduation for light and severe tricuspid regurgitation. And why is it interesting for us? I cannot say immediately what is the regurgitant volume in the failing Fontan patient, but the vena contractor is about 20 millimeters, because this is the diameter of the conduit that we put in between as a vein. And it was already demonstrated in different tools, diagnostic tools. For example, in this publication from 2000, they said that the Fontan flow is dependent to the normal breathing. For example, here, respiratory effect, inspiratory and expiratory, was significant in TCPC, 3.4 times higher as in the normal circulation. And in another one publication, they measured it invasively on heart catheterization, in 12 patients 1 year after Fontan, and they also said this with this wave intensity analysis, also comparison between expiratory and inspiratory pressures, that the inspiration acts as a second driving force and increase the pulmonary blood flow in the Fontan circulation. And in this recently published a couple of years ago from Keeley group, eventually someone at here then can comment better as I understood, but in this index, respiratory to cardiac index, the amplitude ratio, the fractional retrograde flow, if it's more than 15%, this backwards flow is more than 50%, then respiratory was significant in the maintaining of the normal circulation. And the retrograde fraction of venous flow was in average 10%, but up to 30%, where we would expect it. For example, in atriopulmonary connection, or eventually in the failing Fontan circulation, where the percentage of the backwards flow much more higher. And also in acquired cardiology was some attempts were published to improve this situation. And they said, for example, in this publication, that not just left-sided valve should be improved, but also the right-sided valve should be improved. And they measured, interestingly, the liver stiffness to say what time point is better for this. And they said that 15 kilopascal may be used as a preoperative risk. And they also said in the invasive implantation of the tricuspid valve in acquired cardiology disease, that it was associated with improvement of the liver function. And the kidney function remains stable. Therefore, it is recommended to improve this backwards flow from tricuspid valve to improve the liver function. But as we know already from William Harvey, the two problems are connected to each other. Therefore, eventually, it is also the solution for Fontan patient. I don't know. But what we know, that, for example, measurement in our patients group, not 15, but 25 kilopascal of liver stiffness was recognized in this as average in these more than 80 patients 10 years after Fontan. Therefore, the cutoff point that acquired cardiology recommend to deal with tricuspid valve was many years ago in our patients' population. And now, back to the roots. This is the picture, the old picture of Hôpital Tondu, where the first Fontan operation was done. Of course, not in 30s, a little bit later, but it is never too late to recognize that a couple of valves were put within the Fontan circulation. 2 valves, pulmonary and aortic homograft, or just 1 valve, because the idea was, of course, to do something against this backwards flow, as in the normal right ventricle. And 20 years later, if the summary of the data from Bordeaux and Alabama Birmingham, they said for 300 patients, where about 1/3 of them were operated with this valve insertion, that the prognosis is not so good. This is, for example, here are the patients which have something others, not the directly connection, valves or conduits. And after 15 years, we have the mortality of 55%. And they said that a right atrial to pulmonary artery valve conduit is one of the early hazard risks for death. But now, 30 years are passed, and eventually we have better solutions for this idea. But on the same time, for example, 1968, it was summarized, and 27 valve xenografts were inserted, and they said, despite of very high early mortality, but it's not more to the modern years, they said that in 90 survivors, the leaflets were visualized to open directly after atrial contraction. But of course, it was 86. We do not know what has happened with these patients now. 35 years have passed since this publication. In this summary, 66 melody valves were put directly in the primary in the Fontan circulation up to 2013. And they compared with Dacron and Goratex, and they said that Goratex is better. Because the proportion of thrombosis was high in the patients after melody implantation, there were 7 patients with thrombosis, But in the Dacron group was also 6 patients with thrombosis. Of course, this data should be analyzed a little bit more precise to say what is the problem, to understand what are the anticoagulation rules and so on. Therefore, they said it's not be considered as an option for TCPC, but it is difficult to understand why. And they said it may be that there's no protection against liver fibrosis, but it was measured only in 8 patients of 66. It's also difficult to analyze what is the problem. And they said it is 18, but we have our population of 25. I don't know, is it the same or not? Therefore, the analysis is a little bit difficult. But, and that was already demonstrated. The problem was in these 4 patients where interventionally the valve was put. We do not know should it be done also in the failing Fontan patients or should it be done primary if we would have the passing valve. But in 2 patients, there was no function of the valve. They were just open, but without closing function. And it is not clear what volume it is necessary and what pressure is necessary to close this valve in this position. But what we know, the future of all these biological proteses, at least till now, xenografts, homographs, melody valves is limited by the time, and not everyone will reoperate these patients. But if we would recognize that it's possible to deal with interventional, eventually we will have another solution. In the models, it was already demonstrated that it can bring improvement in the Fontan circulation. And what they had in 2015 was published, 12 to 15%. The power loss across TCPC was improved. Therefore, the flow was better. It was dependent on the patient vascular impedance. It was also melody was put within the Fontan circulation. It is very simple construction. You need just about 100 of tubes, and you can repeat it on your kitchen. This Berlin heart, and with inspiratoric solution, and with the valve within this Fontan connection. And another one publication, which was already demonstrated by Jack Rychik, they said also that the upstream hepatic venous pressure was reduced 5 to 10 millimeter mercury. But 5 to 10 millimeter mercury is a huge step in our circulation. And also this energy loss was improved up to 50%. Therefore, it may be a suggestion that the implantation of the valve into venous connection may make sense. And also in this final publication for mechanical assist device, there are 2 valves. The picture is very similar to original Fontan publication, and they also said that it should be a kind of pumping construction in between to open these valves. And it was already done. They try to create this engineered heart tissue generated from ventricular heart cells on neonatal rats, fibrinogen and thrombin, and they implanted this contractile tissue around the superior caval vein. And they made autopsy. They analyzed these rats 7, 14, 28, and 56 days after the implantation. And it was no stenosis demonstrated on MRI. And this tissue around the superior caval vein remains with contractile function in vivo and in vitro after the explantation. Therefore, eventually, and that was their idea, and I would say it is a good idea, we do not need just valves. We need something of contractile tissue between these 2 valves, because as we learned, we need power to open these valves. Eventually not 100 millimeter mercury, but at least some power. Therefore, the idea was to perform the animal study. Due to some logistical problems, we cannot still start with this study, but we hope to have a good valve. Where is Boris? Yeah? And it was a study with sheep, and now they are just waiting for our progress, and we will call them all to accompany us in this study. But the question is, tissue-engineered valves, the new modern valves, should it be done primarily or later? What is the cutoff for decision if you make it later? And do we need some special contractile materials to get this? Therefore, the take message home for me was, I'm strongly convinced that the TCPC should definitely be established with the valve, or not. And therefore, just a question for audience, who would say we need the valve in the Fontan connection? No one? Who would say we do not need a valve in the Fontan connection? Oh. Okay, thank you for your attention.
So thank you. That's fantastic. We're being very provocative here. There is obviously a theme in our presentations here. So it would seem to me, particularly I was struck by the angiographic images that you showed of the patient who had beautiful flow forward and then the patient who had retrograde flow without a valve, right? So these were contemporaneous patients. And then intuitively, it almost seems as if the valve is going to have the most impact in the patient who has the better flow, because that's going to open the valve and you will then be able to most efficiently create upstream drop in pressure. The patients who have downstream impedance to flow, although they may theoretically benefit clinically most from some improvement, I just still find it hard to understand how a valve is going to help in that circumstance if you don't have something to drive blood through the valve and open the valve. So particularly the study from Paris that I showed and you showed as well, out of those 4 patients, 2 of them did not have demonstration of opening of the valve during any of their echo imaging. So it's more of a comment than anything else, but the question might be, don't you think that it's not a valve alone? It is in order to create the most optimal efficiency, it's a valve and something that in the most minimal way is going to drive blood forward as well. Either a contractile conduit or some other impetus to drive blood forward, improving the sucking downstream performance in some way. To me, my sense is that a valve alone in a current TCPC is not going to make too much of a difference. Your thoughts?
Yeah, of course, I can start with the guidelines and recommendation for Fontan circulation. All these points are important to maintain the good Fontan circulation. We cannot hope that we just insert a valve and then we will have normal. What does it mean, normal? Then we have better Fontan circulation. We should start with, I don't know, with exercise in Fontan patients. We should use all possibilities to improve the flow. And of course, in this sample, what was very provocative, this patient has bilateral diaphragm palsy. Therefore, I found some sample which is severe deteriorated function. But contractility and good valve, from my opinion, can improve the Fontan circulation.
Question.
The problem we have is we measure in the cath lab patients who are lying in this position. And so all the venous pressure is at one level, and this is 20, or just name a figure. I once did a patient in an upright position. So on day 1, we did the normal Fontan evaluation, left the sheath inside. Day 2, with the consent and everything, we put him standing upright in the cath lab, zeroed here, and then we took the pressures there. And I made an angio. And this looks totally different. So if you take all these Fontan calculations and the pressure is the models you have, the hemodynamics you have in this position, that's not reality. And I think perhaps in favor of this valve idea, when you stand upright and the pressure goes in this direction, at the size of the liver it was, I think, 30, the pressure. So it's totally different. And then you can say, where you zero? Do you zero at the atrial level, a little bit higher, a little bit lower? So every centimeter downwards, and there are formulas for this, gives you totally different numbers.
Thank you for the comment, Nick, because eventually we have the pressure to open the valve, but we need a volume to close the valve also. And this is the way why we thought about sheeps for our animal model, because they do not in an upright position.
Yes, Felix, go ahead.
A very interesting finding in these patients who had been established with the implantation of a valve was that they didn't find a valve function. So if we believe in that dogma that inspiration will increase forward flow, do you think that if we can demonstrate that in a breathless patient, the sucking mechanism of the atrium will be able to open and close the valve, will be a proof of concept?
Eventually, of course, if we can support the idea that we have some mechanism to open the valve, then we can hope that more people in audience would be for the implantation of the valve. Of course, when we need it, yes.
I have a little bit comment to do about the 4 patients who had the valve, because they were done by the Necker group. And it all started because when I was with Johannes in London, in Philip Boniface, he asked me, well, what if we put a melody valve inside a Fontan? So I tried to do a model of Fontan circulation. And all the thing about this model is how to get a regurg in the Fontan. It was the main part of the it's difficult. It's difficult. And I was quite convinced at that time that of course, you can get a regurgitation in the Fontan. You need high compliance, you need pressure differences in the upward and downwards. But I was convinced that this is not the problem of this patient. And of course, the valve works very well. When you have a regurg, you get rid of the regurg. And the volume to close the valve is almost nothing on the melody valve. So it's very efficient. But I think it's not the problem. So, but it works. But it's not the problem. I'm convinced. I was convinced that, but maybe you can try to convince me of the other way around. But
yeah, you mean just if we will have some solution to leave the valves closed every time, then the function will be also for long term better. But do you know why it was in this open position? What was the problem?
Yeah, the thing is, so Johannes Benjamin told me, well, you did some research. What if you put the valve? And so we took some patients who had a regurg and were not doing well. But most of the time, the percentage of regurgitation in terms of time during diastole studies is very low, and it depends on the respiratory cycle. So I mean, like 95% of the time, it's anteroral flow. So most of the valve on the 4 patients was mostly open all the time. So they were not doing their job of being a valve in circulation. But that's why the percentage of time where the retrograde flow is very, very narrow in these patients.
Thank you for this comment.
Take one more question. Yes.
Carsten Rickers from Hamburg. Thanks for both great talks ahead. And you mentioned the study that we did in Kiel with the MRI study, where we're looking at the driving force of the Fontan circulation. I conducted this study. And what we did is we triggered the flow in the vena cava during the respiratory cycle, and then we did the same thing for cardiac cycle. So with 60 phases and 25 phases in the cardiac cycle. And our physicist, Dominic Gabbard, he programmed a so-called physium matrix to figure out what is the percentage of respiration or cardiac function for driving the forward flow, the cardiac output of the Fontan circulation. And actually, it came out that the respiration has almost no effect, less than 10%. It's only the systolic cardiac function. And referring to what Felix said. And secondly, in terms of the sucking function of the atrium, I don't really see that, because we looked at many Fontan patients, mostly hypoplastic left heart, and there's almost no atrial function. The atrium is often stunned, mostly. There's not a lot of function, particularly in those with lateral tunnel. And important is, again, the systolic and diastolic function of the ventricle and the function of the valve. Now, we know from our clinical practice that those patients with impaired valve are often the worst Fontans, with valve insufficiency. So, and I think it's a very good idea to start with animal studies and try probably valved, and valve conduits or so. Thanks.
Thank you very much.
Great. Thank you very much.